Yeah, I think we'll start because it's time. Okay, so today we will have a seminar. So Vikas will be talking on malignant tumors of the larynx. So he's prepared a very extensive presentation, but very good one. So it's quite an important topic because you do get a lot of short notes from this topic. So let's start the discussion and let's start the presentation. Then we can, if there are any questions at the end, we will have it at the end, not during the presentation, but at the end. Okay, so Vikas, you can start.
Good morning, ma'am.
Good morning.
Just a minute, ma'am. I'm presenting the screen.
Okay.
Ma'am, is the screen visible, ma'am?
Yeah, it's visible to me.
Good morning, everyone. So today we'll be dealing on the malignant tumors of larynx. First, these are going to be my learning objectives. We'll just see a short epidemiology and risk factors slide, and then we'll just try to stage and classify it. After that, we'll try to describe each stage and evaluate, like how are we going to evaluate the malignancy of the larynx, and then how are we going to treat it. Now, going into the epidemiology, generally it is said that males have a higher risk of laryngeal cancer than females. It's obvious that smoking is one of the most common risk factor, and it is more associated with males than in females. So this was a 2005 ICMR report which says that 4.79% of cancers occurring in male are laryngeal cancers, whereas the same is only 0.47% in females. But nowadays, due to increased Western trends where there is like smoking and alcohol more common among females also, so the incidence is increasing. Coming to the main or the most common risk factor for laryngeal cancer, that is smoking. It is said that smoking has 20% more risk than people who don't smoke. At the same time, filtered and light tobacco have 50% lesser risk when compared to the black tobacco or commercially packed ones. Like they have less risk than the rolled cigarettes. And alcohol is also another common risk factor. When alcohol and smoking are combined together, the risk increases by 15 folds. Coming to the other risk factors, first one is the radiation. If a person has, if she or she had any previous radiation exposure, either to any thyroid disorders or some kind of that, it increases the risk of laryngeal cancer. Next one, it is familial. And if the person is working in areas where he is exposed to asbestos, nickel, or any petrol products, etc., he is going to be more prone for laryngeal cancer, and it is more common in blacks than in whites. That is a type of laryngeal cancer called verrucous carcinoma, which is most commonly caused by the type 16 and 18 of human papilloma virus. Dietary factors are also noted. GERD is also a common risk factor for laryngeal cancer, and alkaline reflux is also one. Coming to the genetics, if there is any aneuploidy or an alteration in the chromosome region 9p21 on which there is a p15 gene, or if there is any alteration in the 17p13 region chromosome which affects the p53 gene, or if there is any amplification of the proto-oncogene 11q13 which eventually leads to amplification of oncogene cyclin D1, these all causes laryngeal cancer. Now coming to the pre-malignant lesions, they include the hyperkeratosis, which may be with or without atypia, carcinoma in situ, and invasive carcinoma. Coming to the staging and classification, this staging and classification was given by AJCC, which stands for the American Joint Committee of Cancer. So, first, they have divided the larynx into three sites based on three imaginary planes that they have drawn. And depending on that sites, they have further divided it into subsites, and staging is done so that it will be useful for us to plan for the treatment and also to assess the prognosis. So the first line, the first horizontal plane is drawn at the junction where the ventricle meets the true vocal cord. This is the ventricle, this is the false vocal cord, and this is the true vocal cord. This line exactly, this line of the plane which passes exactly at the lateral margin of the ventricle and true vocal cord junction. This is the first plane. So whatever is above it, the part of larynx which is above this plane, we call it the supraglottis region, and the second plane is drawn just 1 centimeter below to this, and this region is called the glottic region, and this region comprises the true vocal cords. From this point to a horizontal plane which is drawn exactly at the lower border of the cricoid cartilage, we call that as subglottis region. So this is the cricoid cartilage. At the lower border, we draw the third horizontal plane. Below this is the extension of the trachea. Now, this is another view, lateral view. Here, I would just emphasize on one point. This region is called the vallecula, and now it is actually here. So, this is the hyoid bone, and this is the hyoepiglottic ligament, and this is the epiglottis as such. So, again, the epiglottis, we say it as two types. The suprahyoid epiglottis, which is at this point, the tip of the epiglottis, and the infrahyoid epiglottis, which is here. So we'll just see how it is significant in later slides. This is another picture. And before that, we need to also see another thing, the space between the epiglottis and the anterior part of larynx. This is called the prevertebral space, sorry, pre-epiglottic space, beg your pardon, pre-epiglottic space, and it is filled by the pre-epiglottic fat. Below this, as an extension to that, we have the paraglottic space. Now, moving on to the subsites, as said earlier, the AJCC classified larynx into three sites, and in those three sites, we have various subsites. So, the first one, under supraglottis, we have a large number of structures, like we have epiglottis, as said earlier, the suprahyoid epiglottis, this one. Both lingual and the laryngeal surfaces are included. And then the infrahyoid epiglottis. After that, we have the araepiglottic folds. The laryngeal surface alone is taken into consideration for supraglottis. Then we have the arytenoid cartilages, which are located on the posterior aspect here, and the ventricular bands, which are also called as the false vocal cords. So these are all subsites which come under supraglottis. Moving on to glottis, in glottis, this region extends between, as I said earlier, the second horizontal plane, the first horizontal plane and 1 centimeter below that. Till that, it is glottis region. It consists of true vocal cords, which include both anterior and posterior part. Here, this is actually the, we are seeing it from the front. So vocal cord as such will not be fully visible to us. This is the anterior portion of the vocal cord that is visible to us. Here, this is the true vocal cords. Now, moving on to the subsides under subglottis, the entire region that is below the second horizontal plane till the lower border of cricoid cartilage, we classify it as subglottic region. This is another picture, that is the enlarged picture of the same thing. Next important thing will be the TNM staging of this laryngeal tumors. Generally, again, this TNM staging is again proposed by American Joint Committee on Cancer, and this particular staging was proposed way back in the year 2002. So now, this staging depends on three components: T, N, and M. Uh, Depending on the extent of the disease, nodal or distant metastasis that has occurred. Based on this TNM staging, we categorize the tumor into various stages of cancer. So, which helps us in choosing the right treatment and also in assessing the prognosis of the disease. So, coming to the TNM things, T is a factor that indicates the tumor and extent. So, we have T1, T2, T3, etc. And N indicates the regional lymph node involvement and the size. So, it has NX, N0, N1, and N2. And M is a component which indicates the distant metastasis. We have three components there: MX, M0, and M1. Same like in previous thing, NX and MX are where the lymph nodal status or distant metastasis can't be assessed. If you can't assess it, you're going to put X. If the metastasis is absent, just put 0. Moving on to the deeper classification under the TNM staging, we have again the T component is alone divided into again supraglottis, glottis, and subglottis based on the involvement. The first thing is, what I just want you all to remember is, generally in first stage or T1, the vocal cord will have normal mobility. In T2, the vocal cord's mobility will be impaired, but it will not be fixed. In T4A, there will be invasion of soft tissues of the neck and the thyroid cartilage, and in T4B, there will be involvement of the prevertebral space, and it also includes carotid artery. This component is common whether it is supraglottis or glottis or subglottis. Only the case is in supraglottis, in T1 stage, tumor is limited only to one subset of supraglottis. That is the suprahyoid epiglottis or infrared epiglottis, false vocal cord, whatever it is, only one subset is involved in tumor stage 1. In stage 2 or the T2, tumor involves mucosa of more than one adjacent substance of supraglottis, or it may extend into the glottis, or it may involve any region outside the supraglottis like the vallecula or the base of the tongue, spinal sinus, etc. But here the larynx is has impaired mobility, but it does not appear to be fixed. In T3, you have a tumor limited to larynx with vocal cord fixation, and it involves any of the following spaces which I've already shown you earlier: post-cricoid area, the pre-epiglottic tissues, or the paraglottic space, and minor cartilage invasion. Now, coming to T4A stage, the tumor invades through the thyroid cartilage here, and it also invades the soft tissues of larynx like trachea, etc. Now, coming to the T4B stage, here it involves the prevertebral space, and it also encases the carotid artery. This can go, it can either go backwards and this can happen, or it can extend down and involve the mediastinal structures also. Now, coming to the glottis, again here the vocal cord status, which I have said earlier, remains the same. Only thing what varies is, here I said earlier, glottis only comprises of the true vocal cords, both anterior and posterior side. So based on that, we give the T1 staging. In T1, tumor is limited to only one vocal cord. T1A, beg your pardon. And if it is involving both the vocal cords, it is T1B. In T2 stage, the tumor extends either upwards or downwards, and the vocal cord mobility is impaired, but it is not fixed. In T3, vocal cord is fixed, and the tumor invades the paraglottic space. And in T4A, tumor invades thyroid cartilage or any other thing like soft tissues of neck, etc. In T4B, tumor invades the prevertebral space and encases the carotid artery, same like above. In subglottis, yeah, it is just similar. In T1, tumor is limited to one particular part. In T2, it is extending either upwards or downwards, but it is still not extended into the spaces. In T3, it will go extend into the pre-epiglottic and para-epiglottic spaces. And in T4A, it involves the cartilage, etc. And T4B, it involves the preaortic spaces. Now, lymph node status, as I said earlier, in NX, you don't have, you cannot assess the lymph node status. In N0, lymph node metastasis is not present. In N1, metastasis is present in a single ipsilateral lymph node, that is, lymph node on the same side of the lesion, which is less than 3 centimeter in greatest dimension. Now, for greatest dimension, I just want you to understand that generally, if suppose it is like this, if the lymph node is like this, you only tend to take the dimension which is greatest. So this dimension, which is greatest, this is only taken into consideration. If it is less than 3 centimeter, it is considered as N1. Now coming to N2, metastasis is again here the size of metastasis it's crossed over 3 centimeter, but it is less than 6 centimeter as the greatest dimension. So it can either be a single ipsilateral lymph node or multiple ipsilateral lymph nodes, or it can even cross over the other side and cause bilateral or contralateral lymph nodes. But nothing is greater than 6 centimeter in the greatest dimension. This is what is mentioned 2 8 and 2 8 and 2 b and 2c based on the involvement. It is single or multiple or if it is bilateral. N3, here the metastasis of lymph node has crossed more than 6 centimeter in the greatest dimension. Moving on to the distant metastasis, MX indicates it cannot be assessed. M0 is no distant metastasis, and M1 says that we have distant metastasis. Now, stage grouping, it is just simple, just that the M status remains 0 in all except stage 4C. So that is easy to remember. And in stage 0, of course, T, you cannot assess T and N0, M0. In stage 1 and 2 take into consideration only the T factor. In stage 3, there is N1 stage of lymph node involvement, and tumor, it can either be T1, T2 or T3. In stage 4A, the tumor can be like T1 to T4A, any of this, it can have any of the status, and the lymph node can be N0 to N2. In 4B, it is obvious that the tumor status should be T4B, or and it can have any lymph node any stage of lymph node metastasis. And if it has stage N3 of lymph node metastasis, then any tumor grade is accepted. Now coming to the histopathology, we have three things. Grade 1 is well differentiated, grade 2 is moderately differentiated, and grade 3 is poorly differentiated. Now this I just wanted to show you the post-cricoid region, which I said is important in the when staging the tumor extent of the supraglottis region. Now, histopathology, generally vocal cord carcinomas are well differentiated lesions, and they are also the most commonly seen laryngeal cancers. Supraglottis are anaplastic, and verrucous carcinoma, pseudocarcinoma are all kinds of squamous cell carcinomas. Sarcoma lymphomas are rare here. Now, moving on into the each particular topic per se, just remember one thing. As I said earlier, vocal cords is in glottic region, and it is easy to remember that whatever is above vocal cord, you can say that it is supraglottic region, and whatever is lower the vocal cords, you can call it the subglottic region. So this is what is shown here. These are the vocal cords. Above that, region which is involving the vocal cords, it is glottic cancer, and if it is below the vocal cords, it is called subglottic cancers. The first one, supraglottic cancer. This is actually less frequent than the glottic or the vocal cord cancers. Now, coming into the order of occurrence, it is most commonly seen on epiglottis, then false vocal cords, and then the array epiglottic folds. Generally, the patient reports late because it has not involved the vocal cords, and hoarseness of voice is generally the most common symptom that patients present with laryngeal cancer. But here, because the cancer is in supraglottic region, unless and until it extends into the glottic region, you won't have the hoarseness of voice. So other symptoms are not going to give an exact picture of this supraglottic cancer to the patient unless and until we examine them. So generally the patients tend to report late, and by that time lymphatic spread has already occurs, and that indicates that the prognosis is generally poor here. Now coming to the clinical features, generally the patient is silent. Most commonly presenting symptoms are throat pain, dysphagia, referred ear pain, or if the lymphatic or nodal metastasis has happened, you can check for the lymph node masses in the neck. Late symptoms like hoarseness of voice occur when the tumor extends into the glottic region and involves the vocal cord. And if the tumor is too large, it could cause obstruction of the airway and lead to stridor, respiratory distress, etc. Generally, cancer symptoms like weight loss also can be seen. Coming to the spread of the tumor, superiorly, it can spread into the vallecula, or it can spread over into the base of the tongue. Laterally, it can spread into the pyriform fossa, which is located somewhere over here. Anteriorly, the infrahyoid growths or the anterior false vocal cords, the ventricular bands, they can extend into the epiglottic space and eventually penetrate the thyroid cartilage. Inferiorly, the tumor can go into the glottic region. Lymphatics here, this area is rich in lymphatics, so it can occur early. Most commonly involved nodes are upper and lower jugular nodes. And when it is involving the epiglottis, the bilateral lymph nodes are going to be affected. The lesions appear as exophytic if it is in suprahyoid, or if it is somewhere else, it can appear as ulcerative type of lesion. This is a picture of supraglottic cancer involving the anterior epiglottic region. This is a picture where we see that there is involvement of the false vocal cords here. This picture I have taken from Dingra book, and here like the growth is on the epiglottis, and this region here it is the array epiglottic fold. So it has involved the left array epiglottic fold. Here you can see this is not very clear, but this has actually involved the pyriform fossa on the right side. Right false vocal cords and pyriform fossa both are involved here. Now coming to the next common thing, the glottic cancer. This is the most commonly seen laryngeal cancer. Most commonly, it is seen on the free edge and upper surface of the vocal cords in the anterior and middle third. Generally, in the anterior regions, the both the vocal cords meet, right? Like in the anterior commissure. So, if the lesion occurs in the anterior parts, it is most commonly seen that from one side it easily spreads to the other side of the other vocal cord also. Now, clinical features, because they're involving the vocal cords, they affect the vibratory capacity of the person, and then they present with hoarseness of voice, which is the earliest symptom that a patient can uh, present to us with. Now, airway obstruction can occur due to the large growth and also the accompanying edema, or if the cord is fixed, this can all cause stridor. Now, till now, I have been saying that there is an entity called vocal cord fixation. Fixation. Now, what is this fixation? Vocal cord fixation is nothing but cords are immobilized, not due to any nerve pathology or as such. It is immobilized due to scarring of the vocal cord tissue. Now, coming to the spread of the glottic cancer, local spread upwards, it can upwards in the sense superiorly it can spread into the ventricles, or it can involve the false vocal cords. Downwards, it can enter the subglottic region. Anteriorly, it can and if it involves the anterior commissure, it easily crosses over and involves the opposite card also. Posteriorly, it involves the vocal process and the arytenoid region. Now, if the vocal cord is fixed, it means that the disease is more probably spreading to the thyroarytenoid muscle, and that indicates a very bad prognosis. And because the region is not very much very rich in lymphatics, the cord region is not very rich in lymphatics. Lymphatic spread is seen only if the lesion spreads beyond the membranous cord. Because we identify it early, the prognosis is generally good. Now, next is here the lesions appear like mild thickening of the cord or a raised nodule or even an ulcer. And anterior commission lesions appear as whitish granulation tissue. So this is a picture where a picture shows involvement of the vocal cord and also in the anterior commissure on the left side. This is the epiglottis. Here again, here we see that there is involvement of the right vocal cords. This I can say that there is only unilateral involvement of the vocal cord. You can see the thickening of the vocal cord. So this can be classified under T1A stage. Okay. So next is this here. This is a picture where you can see the involvement of this vocal cord over here. This is thickened, and this is again the T1A stage, I guess. And this is after surgery. I mean, sorry, beg your pardon. This is the normal vocal cords. I've just put to compare these two pictures. This is the normal vocal cord, and here you can see the lesion here. Now, this is the lesion, a whitish lesion involving the anterior commissure. A CT scan picture. This is the epiglottis, and these are the vocal cords. So this lesion is below epiglottis, but it is vocal cords not involving them. So this is the cancerous growth. And based on the location we see here, this is not a glottic type, this is a supraglottic type. I have just misplaced this slide, sorry for that. Now moving on to the subglottic cancer. Here, generally, this is the least common laryngeal cancer because, this extends below the glottic area till the lower border of cricoid cartilage, and the patient reports very late to you unless the tumor is very big and causes respiratory distress or stridor. These are the most common presenting symptoms. And here you get hoarseness of voice, and that is due to infiltration of the thyroarytenoid muscle and involvement of the recurrent laryngeal nerve at the cricoarytenoid. The spread locally can easily spread over to the opponent side to the anterior wall. Above it can spread into the vocal, it will extend into the vocal cords, which is generally late involvement. It can go to the trachea, and lymphatic slug, it can either metastasis into prelaryngeal or the Delphian lymph node, pretracheal lymph node, paratracheal lymph node, the lower jugular lymph nodes. Here the lesions appeared as raised submucous nodule in the anterior. This is a picture of cancers below the vocal cord. So this is a subglottic type of cancer. This is a CT picture of the neck showing a subglottic cancer. These are the vocal cords. So it is not involving the vocal cords also. It is below the vocal cords. So this growth is a subglottic cancer. This is a picture taken again taken from Bingra. It is mentioned that this actually looks like a glottic cancer which has spread into the subglottic region. Now the last variety is the verrucous carcinoma. It is generally caused by human papilloma virus type 16 and 18, slow growing and locally aggressive tumor, which is actually a well differentiated squamous cell carcinoma. The most common site is oval cavity, and larynx is the second most common site of verrucous carcinoma. So as seen here, the lesion appears as an exophytic or a fungating carpet-like lesions. And there is actually inflammation seen around the lesions, which lead to enlarged neck nodes, beg your pardon. And histology, it can be visible as the hyperkeratotic keratitic squamous epithelium. There can be minimal cytological atypia, papillomatosis, or club-shaped retiridges. Now moving on to the diagnosis part, the evaluation part of this. Generally, we have four broader classification of or in the ways which we can evaluate the patient. First one is the clinically by history or examination. Then you tend to do a indirect laryngoscopy either through the mirror, or you can do direct endoscopes or stroboscopes, etc. You can also use a direct laryngoscopy, flexible laryngoscope or micro laryngoscope, etc. And after that, you confirm it with many things like X-rays or CT scans, etc. Now, this is generally the timeline which is practically happens. It generally practically happens. So first, the patient comes to you. You take history, followed by you examine him. Especially, you have to be more conscious over examination of neck. Then, followed that, the patient is there. So you just put him perform an indirect laryngoscopy there. After that, you can do a direct laryngoscopy if needed. Then, based on this, you give or you have a picture of what lesion he is having. So this three and your query, what the clinician suspects, what has he seen in this preliminary investigations like indirect laryngoscopy, direct laryngoscopy, and all, what he has seen in that has to be conveyed to the radiologist along with what he expects. So this clinician and radiologist have to always be connected here. So only when like when we give an idea of what are we going to expect, what did we see, he's going to give the radiologist is going to give a perfect picture of what we need actually. So now the clinical evaluation. First thing, you can just evaluate the patient's history. This is generally based on the symptoms, which include the hoarseness of voice or throat pain, dysphagia, etc. Generally, if the patient is in a non-cancer age group, you can evaluate hoarseness, which is persisting for more than 4 weeks, because supraglottic and subglottic tumors generally present without any respiratory distress. And next one is this highlighted thing is actually a dictum. You should follow it as a dictum that any patient in the age group of the cancer age group, they have to be evaluated for laryngeal examination. I mean, they have to be ruled out for laryngeal cancer if they have increasing hoarseness of voice for 3 weeks or more. This is followed to be most important thing, and it has to be followed as a dictum. Now, coming to the examination part, you need to check for the vocal cord mobility, apparent or fixation of vocal cords, which might happen due to mass effect of the tumor. You have to check for infiltration of thyroretinoid, cricoretinoid, or like recurrent laryngeal nerve. This will help us in managing the patient and also in assessing the prognosis of the disease. Next, we have to evaluate the extent of the disease, whether has it involved vallecula or base of the tongue, etc. And if possible, make a drawing uh, of the patient's vocal cord showing the extensions. Now, coming to the clinical evaluation, examination of neck is very important, and we need to keep in mind two things here. One is check for any extralaryngeal spread. Two, and evaluate the lymph node metastasis. Growth of anterior commissures or subglottic regions, they can directly spread into the cricothyroid membrane, and this can cause a visible midline swelling. Or sometimes they can involve thyroid cartilage and cause perichondritis. It can also involve thyroid per se and also the strap muscles. Now, followed by this, you have to check for lymph node metastasis. Most commonly, just check for the cervical lymph nodes. Now, coming to this sign, demarquase sign. Generally, when you swallow, your larynx is going to elevate. So when this is absent, that is absence of elevation of larynx during swallowing, we call it the demarquase sign. Supraglottic cancers can be easily diagnosed because they're associated with high incidence of cervical lymph nodes. You can just evaluate it clinically. Moving on to indirect laryngoscopy, you can either do a mirror examination, which can give you better color and depth perception. Before performing it, you have to advise the patient to swallow his secretions. Coming to endoscopy, you can perform a rigid endoscope or a flexible endoscope, and sometimes they put a small needle so that you can even take a small piece of the tissue without requirement of anesthesia. You can also, through the endoscopes or whatever it is, you can document the pictures. You can perform post examination. Now, generally based on appearance of lesions, you can expect what type of cancer it is. Like if it is involving supraphytic, infrared is going to be acid. It is involved vocal cords. It is going to present as a nodule or If it's involving anterior commissure, it is going to present as whitish granulation tissue. Subplotic region, it presents just as raised submucosal nodule. Coming to the next thing, you have to check for the vocal cord mobility. This is very, very important because this might give you an idea if the tumor has infiltrated deeply into the thyroarytenoid or the cricoarytenoid joint. Then, as usual, you have to check for the extent of the disease, whether it has spread to vallicular, base of the tongue, or piriform fossa, or it has extended deeper into glottic region or subglottic region, etc. So this is a picture, and this picture, uh, this is actually taken from the American Journal of Neuroradiology. The first picture is an endoscopic view of the larynx. You can see a large right glottic and supraglottic mass with a invasion of the subglottic region. Here is the lesion. Now this is a axial CT image where the epiglottis is not seen here. So this that means that this is taken in the glottic level. So axial CT scan in glottic level again shows the lesion here. Now this picture is one of the latest advancements. It is the CTVL, that also called as computerized tomography, virtual laryngoscopy. Here you can see a right glottic region mass. This is also taken from the same journal actually. Here the first and second pictures are taken through a laryngeal endoscope, and you can see a bulging lesion on the array epiglottic folds here, and which has also extended into the anterior and medial wall of the apex of the left piriform sinus. So this is the piriform sinus, and you can see the tumor involved here. This picture is actually these two are CT images. You can see extension of the right false vocal cord, and which is extending laterally into the paralaryngeal fat, as shown in the arrow here. And in D picture, we can see that there is involvement of contralateral array epiglottic fold, which extends into the anterior wall of the piriform sinus. So now, this is actually a video of laryngoscopy performed. Just a minute. Here he is going from the mouth. This is the tongue uh, passing over the uvula, and this is the epiglottis. And you can see a lesion on the right vocal cords here. So this is a lesion extending. Okay, it's actually extending below the vocal cords. Now this is another thing. I think the video is not very clear, but here they say that the right cord is fixated, and you can see a lesion here. This is a CT image. Another video showing T3 glottic squamous cell carcinoma. Here, the lesion is on the left vocal cord. Here, you can see that. Now, coming to the direct laryngoscopy, you can perform a micro laryngoscopy, and this can help us in taking the biopsy accurately without damaging the vocal cords. You can even try to palpate the vocal cord for differentiation using the scope itself. And you can even have a laryngeal probe for assessing the extension into the ventricles. We can perform a supravital staining and biopsy by colloidal glue or Lugol's iodine, and this dye is taken up, then that is carcinoma in situ and superficial CA. If the dye is not taken up, you can call it as leukoplakia, or it's most probably leukoplakia, so you can just rule out that. Other investigations include autofluorescence laryngoscopy and lung imaging fluorescence microscopy. Coming to the imaging, generally we first do a chest X-ray to rule out any pulmonary metastasis or rule out any bronchogenic carcinoma or TB. Now, coming to the CT on MRI, the CT is one of the most commonly taken investigations nowadays. So it helps us to assess the extent of the tumor. Also, assess the extension or invasion of the tumor into the pre and paraglottic spaces. If it has destroyed thyroid cartilage or if it has involved lymph node, we can assess that. Next is the PET scan. Differential diagnosis that we have to rule out is fungal laryngitis, sarcoidosis, tuberculosis, and leginous granulomatosis. This we can easily correlate with the clinical and the laryngoscopy findings, and then we can just rule out. This is a X-ray of patient showing the metastasis, pulmonary metastasis. Now, this is a CT image. Again, this I already showed it earlier. This is CT image, and here you can see the tumor. This is taken in the sagittal section. Here, this is taken from the American Journal of Neuroradiology. First picture, this is actually this entire series of CTs are from a patient who has supraglottic laryngeal cancer. So let's see how it is seen here. In A picture and B picture, you can see that there is extension of the tumor into the pre-epiglottic space here. And it is also involving the right epiglottic folds. This arrowhead shows extension of the tumor into the right proof vocal cord. It is from the supraglottic region. It has also extended into the glottis, and it has involved the vocal cord, right true vocal cord. Now, see picture. This just a minute. Okay, so this picture is actually this shows the transglottic invasion of the tumor. Transglottic is nothing but the tumor in the supraglottic region. If it extends or crosses through the glottic region and involves vocal cords, and if it even extends into the subglottic region, we call it as a transglottic extension. So it is generally supraglottic to subglottic extension via the glottic region. Okay, so this pictures C and D show the transglottic extension. Now this ENF is actually of higher level. So one picture was taken when he was asked to blow a straw, and another picture he was asked to hold the breath. So in both the images, they just try to check for movement of vocal cord. So this helps us in assessing whether the vocal cord is immobile or fixed, etc. Now, because of the involvement and stuff, they have involvement of the glottic region, and it like invasion into the spaces, and the vocal cord is fixed, it seems. So they have said that this is the image of a T3 supraglottic cancer. This is another image. Here, the patient actually has supraglottic laryngeal CA. The first one is the standard neck CT taken at the supraglottic level, and you can see the mass in the epiglottis and the araepiglottic folds. Both side of like those araepiglottic folds, it is involved. Now, second image is a axial CT image taken at the glottis level. You can see that epiglottis is not seen here, and it shows normal vocal cord, and the vocal cords are a normal abduction also. So you can say that the vocal cord is not fixed here. Now coming to the C image, section, it is an infiltrative tumor extending to the supraglottic region. Here, this is the vocal cord, and it is infiltrating into the supraglottic region. Here, small paraglottic elevation. D is a sagittal section. Here, okay, the vocal cords are normal here. E and F again, as I said earlier, this is the CT when he is asked to blow a straw, and this is CT when he is asked to hold breath. So the vocal, yeah, this you can make out clearly here. Here the this open here, and here you can see that the vocal cords are closed. So by this you can see that the mobility of vocal cord is normal. This is a picture where there is involvement of the right array epiglottic folds. This is again a CT picture. This is an MRI image. Here, whatever is given in the asterisk, this is the lesion here. A 65-year-old patient who came with laryngeal lymphoma. This picture is a coronal T1 wide MR, and this is showing an isotense supraglottic soft tissue nodule. Okay, that's the only thing I can see here. This is another picture, a CT picture with a lymphoma. The patient is presenting with laryngeal lymphoma. Axial CT, here you can see that there is uniformly enhancing mass on the left vocal cord. I think we are running short of time, so I'll just rush it up. Next comes the CT picture of another patient with laryngeal lymphoma. So here you can see the uniform involvement of the right false vocal cords, and both the piriform sinuses are also involved here. Moving on to the treatment part, we have 5 treatment modalities that are available: radiotherapy, combined therapy, organ preservation, palliative care, and also surgery. Surgery, again, we have 2 types: conservative laryngectomy and total laryngectomy. We'll just run through these things. Radiotherapy, this is generally reserved for early lesions which are in early stages, like T1 or T2 stages. Okay, so here the cords are mobile and there is not involvement of cervical nodes or cartilages. The main advantage of this is, because you're not going to cut off the vocal cords or remove them, the voice is preserved here. And cancer of vocal cord being most common thing, it also has like the best cure rate with radiotherapy. 90% cure rate has been observed. But in case of superficial exophatic lesions of epiglottic tip or the AE folds, you have 70 to 90% cure rate. But when the cords, or if it has extension into cartilages or other areas with nodal metastasis, the results are going to be poor. As said earlier, 90% cure rate is seen with the glottic cancer, so it is the most radiosensitive tumor of both pharynx and larynx. Coming to surgery, there are 2 options: conservative laryngectomy and total laryngectomy. Earlier, they used to do this total laryngectomy where entire larynx, including the hyoid bone, the pre-epiglottic space that I have shown you earlier, the strap muscles, and 1 or more tracheal muscles, everything is removed. What they do is they close the close primarily the pharyngeal wall, and they also suture the lower tracheal stump to the skin, okay, for breathing. The tracheostome is placed there, and along with that, they'll do block dissection of the lymph nodes if they have shown metastasis. So the disadvantage here is the patient will not be able to speak later, and you need vocal rehabilitation after that. So the indications for total laryngectomy will be if there is any T3 or T4 invasion, T4 lesions, invasions of cartilage, lesions of posterior commissure, or if the radiotherapy has failed, or if the cancer has involved all the three regions, the transglottic cancer. Coming to conservative laryngectomy, here we attempt to preserve the voice of the patient, and also permanent tracheal opening is tried to avoid. Chordectomy, partial frontolateral laryngectomy, and partial horizontal laryngectomy are three types of conservative laryngectomy. Chordectomy is the excision of cord via laryngofissure or endoscope. Partial frontolateral laryngectomy is excision of cords in anterior commissure. Third one, partial horizontal laryngectomy is excision of supraglottis, which includes epiglottis, AE folds, false cord, ventricles, etc. The entire supraglottis is removed, but the true vocal cords and the region below that is preserved. So these are nowadays done by minimally invasive techniques like laser-assisted microsurgery, trans and robotic surgeries. Structures that are to be preserved in conservative laryngectomy are at least one cricoretinoid unit. Now, coming to comparison between radiotherapy and surgery, both are actually equally effective. The only thing is, in surgery, you will have to compensate some functions. So, in early stage cancers, radiotherapy is a single modality treatment, but both are options. There are nowadays the conservative laryngectomy is one of the options for voice preservation. But in advanced stages, you can generally do a multimodality therapy. You perform surgery and combine it with chemotherapy or radiotherapy. Most commonly used thing is post-op radiation with or without chemotherapy. That's what I was mentioning. Combined therapy, you either give a pre or post-operative radiation. So whatever cells or whatever it is left out there, the malignant cells, by radiation, you're going to completely eradicate them. So pre-op radiation renders the nodes resectable. So you can easily resect the nodes if you give a pre-operative radiation, but this has high complications. But at the same time, with post-operative radiation, and if it is given within 7 weeks, the overall survival rate is said to be better. Coming to the palliative care, there is something called as endoscopic resection, endoscopic CO2 laser. Now this is slowly trying to come as an advanced treatment without performing or without using a blade or even radiation. Okay, so minimizing the side effects there. So it is most effective in cancer of mobile vocal cords. So it is cost efficient, and the duration of treatment is also very less, and you're not going to have much of complications. T1 lesions of epiglottis can be treated with this, and cervical lymph nodes can also be managed, but with endoscopic laser, you cannot manage that. You have to separately do a surgery and take the cervical lymph nodes. This is actually a small video of endoscopic laser. I'll actually try to send it in group. Actually, we don't have much of time now. This is observation. This is a patient in mid phase. We are trying to avoid total laryngectomy in stage 3 and 4. Okay? So we do injection chemotherapy with radiotherapy, and it is shown that it has better control with laryngectomy and radiation. Comparatively, this has better local control. So the chemotherapy protocols include 3 segments of cisplatin or fluorouracil. Okay? So this is one more thing. If the cancer has involved the thyroids, or in case of T4 glottic tumors or pyriform sinus tumors, or positive Delphian nodes, if there is any cartilage dissection, you have to perform a hemi or subtotal therapy. Coming to the treatment specialist for supraglottic cancer, early lesions T1 and T2 can be treated by radiotherapy, as I said earlier. T3 and T4 have to be taken to total laryngectomy, and post-op radiation should be given so that you can prevent. You can just, if it is carcinoma in situ, you can do a transcriptal endoscopic carboxyl laser and strip the cords. T1, you can do a radiotherapy. If it is extending into anterior commissure, again, radiotherapy is the best choice. If it is not effective, then partial laryngectomy can be done. If it is extended into arytenoid extension, it is also same as above, but here the surgery is preferred first. When it comes to E2 stage cancer, this is just a protocol for treating. Just check if the parts are mobile or not. If it is mobile, take him for radiotherapy, including radiation to the upper neck nodes. If it fails, then do a conservative laryngectomy. Again, if that fails, do a total laryngectomy with or without neck dissection if needed. If the cord mobility is impaired or involvement of anterior commissure is seen, directly take him for a conservative laryngectomy. If it fails, then go for total laryngectomy. Glottic cancers, we have to assess the status of the cervical lymph nodes here. These are all the indications for a surgery here. Status of cervical lymph nodes have to be assessed. Cord mobility has to be assessed. Age of the patient. Status of lung functions or the lung metastasis has to be seen. If there is invasion of cartilage or invasion of the subsides, or if it is invaded into pre-glottic space, all these things you have to assess before taking him for.
Is Vikas there or the connection has got disconnected?
His connection got disconnected.
Okay.
So finally, this
Vikas?
thing we have three open. Ma'am,
Okay, okay. No, no. We have just it's 9:59. So how long will you take?
no, ma'am, only
I will
three, ma'am,
also
three more
slide.
slides. Three more slides,
Okay.
ma'am.
Yeah. Okay.
So in like over rehabilitation, we have three options. We can either ask him, train him to do a esophageal speech, or use an artificial larynx, or you can use a tracheoesophageal speech. This is the picture for an esophageal speech. Here you train the patient to swallow air, and as it enters, you can ask him to hold it in the upper esophagus. Then he can be trained to extend it or expel it into the larynx. When does happen, like when that happens, he can produce voice actually. So before re-swallowing each time, he can speak to up to 6 to 10 words. This is the artificial larynx. We
We
have
are
two
not
options here:
able
electrolarynx.
to sorry to interrupt. We are not able to
Yes,
see
ma'am.
your presentation.
Okay, ma'am. Now, ma'am.
Yeah, now we can see it.
Okay. So this was the esophageal speech. You can just ask patient to swallow air and hold it in the upper esophagus. Then slowly he eject the air into the pharynx, and like that, the other voice modulators modulate the voice, which is generally low, but you can hear him speak up to 6 to 10 words in each cycle. This is the artificial larynx. This retrolarynx, there is a membrane here which generates impulses. When he keeps it on the soft tissues, that produces sound, and the modulators, they just modulate voice modulators. This is the transfer pneumatic device. Again, the tracheostome is there. Here he places the disc and air is produced from there. He makes sure that the air goes into the deeper parts like upper esophagus. From there, he expels the air and he can speak. Now, coming to tracheoesophageal speak, nowadays the most commonly used thing, there is the shin made between trachea and esophagus, just skin fistula. You can say that it's a tracheoesophageal fistula. So the air passes from trachea to the esophagus, and the person can speak. But this has a disadvantage that the food might enter into the trachea. That can be overcome by using new prosthesis. Comes in the process of angioprosthesis. These are actually having valves so that only one-way connection is seen. So that's it. Thank you, ma'am.
Yeah, so thank you, Vikas. That was a very good, very extensive presentation, but I know you did good justice to the topic because this topic is actually a postgraduate topic more than UG topic. But you have covered it very extensively. So Good, I'm happy with that, and I was happy with the layout of your presentation, how you have arranged the material on each slide with the
Thank you,
images.
ma'am.
Okay, so just a few points because we don't have time and I don't want to take the next professor's time. So you mentioned something that fixation of the cord is due to scarring. Am I right?
Yes, ma'am.
Yeah, so that will not be
Yes,
a
ma'am.
very good answer when an examiner asks you that. Okay, this is for everyone who's listening. So there is a sentence in Dingra on page 350, if your Dingra is open. Okay, so when the examiner asks you what is the cause of vocal cord fixity, it is not scarring. It is because of infiltration of the thyroarytenoid muscle. Number one. Number two, either because of infiltration into the cricoarytenoid joint. Number three is invasion into the recurrent laryngeal nerve. So when an examiner asks you why is there fixity of the cord, you can say because of one of these points. Okay, thyroarytenoid muscle, cricoarytenoid joint, or the recurrent laryngeal nerve. That is what causes the cord to be fixed or to be fixity, as Vikas said. Fixity means the palsy of the cord. Okay, so cord doesn't move at all. That is why it is called as a fixed cord. So you have when an examiner in your OSCE or your Viva in your practical exam, especially, they love to ask this question. So they will ask, what is the cause of fixity of the cord? So you need to say this, and scarring will actually put you in trouble because they will ask you more questions about that. What scarring? From where is the scarring? How is there scarring without surgery being done? So it will just invite trouble. Okay, so that is one point which I wanted to correct. Um, so one question I had for you, because is what are the hidden areas of the
Yes,
larynx?
ma'am.
What are the hidden areas of the larynx? Is because then,
Yes, ma'am.
yeah. What are the hidden areas of the larynx?
Ma'am, are you able to hear me, ma'am?
Yeah, now I'm able to hear you. Your mic is muted.
Yes, ma'am.
Yeah.
Uh,
You. Hmm.
like the ventricle, ma'am.
Okay. Then.
Ventricle, and I don't know, ma'am. I only remember that.
Yeah, yeah. So this is also why I'm asking this question for everyone, is because this is also a very commonly asked and a favorite question, especially of older examiners. They love to ask these questions. Okay, so what is the hidden areas of the larynx? It's given in your DICRA on page number 351. Okay, so this also you need to know number one, two, three, four. So one is infrahyoid epiglottis. Then you have the anterior commissure, because many times the petiole of the epiglottis covers the anterior commissure, so you're not able to see that. Okay, then the subglottis. You're able to see the supraglottis and glottis very well, but the subglottis sometimes can't see very well. The ventricle, especially the inferior margin of the ventricle, is very difficult to see. So what are the hidden areas? What do you mean by hidden areas? That is when you do a indirect laryngoscopy with the mirror, or when you do a direct laryngoscopy, these are the areas which could be hiding some carcinoma, but you are not able to see it. That is what it means by hidden areas. So what are the hidden areas in the larynx? It is the infrahyoid epiglottis, the anterior commissure, the subglottis, and the ventricle. These four structures are the hidden areas which you need to know. Okay, so that is one point. Then the next question I have for Vikas is, yeah. So which subside of the laryngeal carcinoma has the best prognosis? Anyone can answer, or Vikas can answer. Is Vikas able to hear me?
Yes, ma'am. Glottic region, ma'am.
Correct. Glottic.
Vocal cord cancer.
Yeah. So why does it have the best prognosis?
Ma'am, we can detect it very early, ma'am.
No, that's not the reason why it has the best
And
prognosis.
also, there is lymphatics are not there, ma'am.
Yeah,
Lymphatics are not much extensive, ma'am.
Correct. That is the answer which you need to give because, as I said, examiner will want like in a minute they will decide whether you have to get marks or not. So you need to give the exact answer that they want to hear. Okay. So the answer is that because of the very low lymphatic drainage from that area, glottic cancer has the best prognosis. The second point is that glottic cancer is the more like when you compare supraglottis, glottis, and subglottis, glottic is the one which is most commonly affected, which Vikas has already said. Okay, the next point that I wanted to re-emphasize that he has already said is that when in the TNM staging, when you hear fixity, immediately think of T3. Okay, so you don't have to, even if when you're mugging up the TNM staging, it may be very confusing initially to, there's such a big staging and, you get very confused, especially in an exam. Okay, and when the examiner asks you, so this patient has, this glottic cancer with fixity of the cord. So what is the staging? So immediately when you hear fixity, you think of T3. Okay, so that is one thing that should bring in your mind. The second thing is that T4A and T4B is the same for all the three. For supraglottis, subglottis, and glottic cancer, TNM staging, T4A and B is the same. Okay, so T3 means vocal cord fixity. Okay. Then the next point which I had made, yeah. Then the next point is that suppose a patient comes in stridor with laryngeal carcinoma to your casualty. What do you do? What is the emergency procedure that you do? Does anyone know? Since Vikas has presented, like I'm directing all the questions to him today, but the next time will be directed to others. Does anyone know? No. Okay, so if a patient comes to your casualty in stridor that is not able to breathe, having a very loud sound, then and stridor, and they have some report saying that he has laryngeal carcinoma. Okay, so the emergency treatment is to do a tracheostomy. Okay, so that is one. Then the next point about the investigation is about the PET scan. Okay, so because what is the full form of PET?
Positron emission tomography.
Tomography. Correct. So why I'm emphasizing on PET scan is that if you have a examiner who's young, okay, because PET scan is what is done nowadays when people, when patients come with you suspect of carcinoma, you've seen it on indirect laryngoscopy or direct laryngoscopy, then you need to know where all, where all it has extended to, what is the extent, what is the how much it has infiltrated. So PET scan is the recent investigation of choice. Okay, so before CT, MRI, definitely we have to do it. But PET scan is something that is being done recently. Okay, so that's why I said an examiner who's younger will want to hear the word PET scan when you talk about the investigations when you have a patient with laryngeal carcinoma. So PET scan is it's an imaging technique similar to a CT scan where you give a radioactive substance. So what is that radioactive substance? Just the name you have to know is FTG 18. That is FDG, which is fluorodeoxyglucose 18. So that is the substance that is given to the patient to ingest. So he takes the substance orally, like taking any food, and this dye will show. Will light up to the areas that there is metastasis. So this is good when there's distant metastasis, when there is nodal involvement which you're not able to palpate or it's too extensive, or to see the extent, especially when it has infiltrated the cartilage or the muscle. Okay, so to see the extent, so this PET scan gives a very good image. Okay, the second last point is about the treatment. Okay, so when you have T1 or T2 lesion, think of radiotherapy. When you have a T3 or T4 lesion, think of surgery and post-op or pre-op radiotherapy. Okay, so this is a very basic point which I'm trying to say because I know that many times, like I've also been in that situation situation where people ask you, okay, so what do you do if it's a T2 lesion? What is your management? So that time, you're so confused, like whether we have to which surgery to do and things like that. So remember basic points: T1 and T2 radiotherapy, T3 and T4 surgery and post-op radiotherapy plus post-op radiotherapy. Okay, and the last point is about the voice rehabilitative rehabilitation. Okay, so there was a question I saw in one of the papers that name four voice rehabilitation techniques following laryngectomy. So Vikas has put the diagram. So that is an important question. Okay, and this tracheoesophageal fistula is the correct term is TEP, tracheoesophageal puncture, TEP, which is the correct terminology to be used. Okay, so these are just few points that I noted down during the presentation. If there is any doubts, going fast. Anyone has any doubts? Okay, if there's any doubt, you all can put it in the group, and because put the video on the group so that we can see it. Okay, so that's a good presentation.
Yes, ma'am. Sure, ma'am.
Yeah. Okay. Thank you.
Thank you, ma'am.